In today's Medicast Masterclass, we are going to learn about renal artery stenosis. Now, when we talk about renal artery stenosis, remember it is also called as renovascular hypertension. Now, if you remember, when we talk about secondary causes of hypertension, obviously renal parenchymal diseases as well as renal vascular diseases, both are very important causes of your secondary hypertension. But overall, let me just put it in perspective that parenchymal renal diseases are more commonly implicated in secondary hypertension as compared to vascular diseases. But remember, when we talk about renal artery stenosis, it's a renovascular hypertension, which we also call it. The most important questions around this topic will be around etiology. So, what causes renal artery stenosis? So, obviously, the most common cause will be atherosclerosis. Okay, so here there is an ostial narrowing of the proximal part of the renal artery, and that atherosclerosis will lead to renal artery stenosis. So here, as you see, atherosclerosis will be seen in a typically person who is like 60, 65, 70-year old person, and the typical presentation will be either hypertension which is suddenly increasing. Earlier the person's hypertension was controlled. Now it is again not no sudden increase in the hypertension or the BP, or his current medications are not able to control his hypertension. Why does anyways atherosclerosis increase the blood pressure? It's very important for you to understand that what happens is, if there is an atherosclerosis of the renal artery, there will be decrease in the blood supply of the kidneys, and what will happen? There will be decrease in the GFR, and to increase the GFR, the renal angiotensin system will be activated, more renin will be produced, and this will lead to hypertension. So this mechanism also you have to remember. So the most important cause, the most common cause is atherosclerosis. In Indian and Asian patients, Takayasu arthritis, also called as pulseless disease, we have learned a lot in detail about this disease when we have learned vasculitis. So when we talk about Asian population, again, this is very important cause, Takayasu arthritis. So this Takayasu arthritis, also called as aortic arc disease or pulseless disease, generally presents in 15 to 30 years of age. Again, in 15 to 30 years of age group, you will never think of atherosclerosis. So this Takayasu arthritis becomes a very important cause during that age group. So we know that it mainly affects aorta and its branches, okay, like common carotid, brachiocephalic, or subclavian. Even pulmonary arteries are affected. And how does this Takayasu, presents? There's a complete presentation of vasculitis. But again, when you examine, you will have weak or absent pulse. Also, there's a very interesting radio-radial delay, which means when you take the radial pulses in both the hand, one pulse will not be will be appearing one after other, so it will not be appearing synchronously. Normally when you take a pulse of a person, both radial artery can be palpated at the same time, the pulse will be felt at the same time. But here in Takayasu, either they are weak pulse or absent pulse, or there may be even a delay in the radio radial pulses. So this is very, very important. The third important cause, not typically seen in our side, but mostly in the Western population, that is a very important vascular cause, that is called as fibromuscular dysplasia. We know that here you will be given a history of a young female, and it's again a vasculitis. It's a rare disease again, and typically they will talk about a renogram which is done, and here you will have this chain of bead appearance. Okay, so you can see the chain of bead appearance which you can see in your fibromuscular dysplasia. Okay, so this is a renogram which is shown in the in the image. So these are the important cause. Now, one important thing and one important option which has been like very frequently given in the examination, and which student get confused, is polyarthritis nodosa. Now remember, polyarthritis nodosa itself causes hypertension. Remember, so a polyarthritis nodosa patient can have hypertension, but in polyarthritis nodosa, it is aneurysms which you see aneurysms and not stenosis. This is a very, very important, when they will say which of the following causes renal artery stenosis, and they will put polyarthritis nodosa in an option, and many students get it wrong. So remember, polyarthritis nodosa, yes, it is implicated in causing secondary hypertension, but remember, it causes aneurysm and not stenosis. So these are the three important causes which you have to remember. when we talk about renal artery stenosis. So how does this patient present with? So, when we talk about atherosclerosis, you will have a 55, 60, 70-year-old person, who he's either having a refractory hypertension or there is a sudden increase in blood pressure. So he will have a, so here is a person, he's been diagnosed hypertensive, and you're giving normal, ACE inhibitors or normal beta, but he's not responding. So even with you're giving, antihypertensive, he's not responding. So that refractory hypertension, or he was normally controlled with the antihypertensive, but suddenly his BP is increased and now it is not controlled by the regular antihypertensive. So that can be a very important clinical presentation, and you should immediately think of renal artery stenosis. Then also, there can be, because of this sudden increase in, blood pressure, there can be an acute left ventricular failure, and this can present with sudden or flash pulmonary edema. Now this question again has been asked, that sudden or flash pulmonary edema is seen in, and the correct answer was renal artery stenosis. Again, when we talk about, atherosclerosis, and especially advanced atherosclerosis, or so we know that abdominal aorta again will be associated with that, and so abdominal bruit. So there will be a bruit which you can hear in the abdomen. This bruit will be both systolic as well as diastolic, and the severity of the disease can be diagnosed or can be correlated with the intensity of the bruit. So again, abdominal bruit can be a very important presentation when you clinically examine the patient. And obviously, because Takayasu in Asian population is one of the important causes, so you will go and measure, look at the peripheral pulses, which can be pulseless. So you can have a pulseless, or you can have weak pulses, or you can find that typical radial delay. So you know the kind of questions they can ask you. They can ask you about the cause of renal artery stenosis. They can give you a clinical picture, and you may have to think in terms of renal artery stenosis and the cause to make a diagnosis. So this is important. Let's look at the management of this patient. So first we have to work up this patient. So what is the first investigation when you think of renal artery stenosis? Remember, the first investigation is ultrasonography. It's a non-invasive and very easy to get ultrasonography done at any center. And what will you find in ultrasonography of abdomen? So you will find asymmetric kidneys. So remember, the side on which there is renal artery stenosis, that kidney will shrink. And to take the extra load of that kidney, that failing kidney, the other kidney will work over time and it will become enlarged. So one kidney is shrinking while the other kidney is getting enlarged. So that asymmetric kidney should give you an idea that you are correct in your diagnosis towards renal artery stenosis. Once you have got, what is the screening test or the best screening test? Again, this question has been asked in the examination. Remember, Doppler of your renal. So renal Doppler is one of the best screening tests. It has very high sensitivity and specificity. The next question they keep asking is, what is the investigation of choice or gold standard? Because it's an arterial disease, so renal angiography will be the gold standard or investigation of choice. Especially the distal subtraction angiography is a very, very, is the gold standard for uh, diagnosing this condition. Then another way to diagnose, and another very important investigation can be your DTPA scan. Especially we talk about a renogram, which is before and after giving an ACE inhibitor like captopril. So that also is called as captopril renogram or DTPA scan. Now we know DTPA scan is basically a functional scan. Okay, so what we do is we take the scan before giving the ACE inhibitor and after giving the ACE inhibitors. So after giving the ACE inhibitors, the site which has renal artery stenosis will, the uptake of the dye will be much less. So again, captogram or captopril renogram or DTPA scan again is a very important investigation of choice. The next investigation may be an MRA angiography. So MRA angiography, remember, it is again, it can give false positive because of the turbulence in the flow. So but MRA angiography is also a very important choice, and in many cases CT angiography can also be done. So it produces very, very accurate image, which makes the diagnosis much easier. But remember, because many of these patients may have compromised kidney function tests, so then that CT angiography may not be possible. So a frequently asked question is, if all these options are given, so look at the question what it says. Initial investigation, ultrasonography abdomen, screening, best screening, Doppler, investigation of choice, and if these are not there, then you can choose between these. Out of these, remember, this should be the first preference in your examination, this should be the second, and this you can put it in the third, CT angiography, because most of these patients are compromised in their renal status. So you do not generally go for CT angiography. So how do we manage these patients? So remember, we talked about hypertension being the main clinical feature. So we will use calcium channel blockers or alpha channel blockers to manage the hypertension. ACE inhibitors can be used, but remember they are generally avoided. Uh, they are contraindicated in bilateral renal artery stenosis. Again, a very favorite question. What is the absolute contraindication? Because we have seen what will happen. So what is going to happen is, already there is a decreased blood flow, and what will happen is, if you give ACE inhibitors, it will dilate the efferent arterioles. Okay, it will dilate the efferent arterioles. So there is decreased blood flow, and you have dilated the efferent arterioles. So what will happen? It will further decrease the GFR. So if you give ACE inhibitors in your renal artery stenosis patient, especially bilateral renal artery stenosis patient, it will lead to decrease in the GFR. Hope you are clear. So what is happening is, we know that there is an you know afferent arteriole which will bring the blood, and there is efferent arteriole which will take out the blood. Now what ACE inhibitors do is, they will dilate the efferent arteriole, so there will be decrease in the GFR. Already the GFR is compromised, already there is a decrease in the blood flow to the kidney. So it can lead to acute kidney injury. So this is very important. Another, especially for your fibromuscular dysplasia patients. Okay, so there is a surgical intervention, that is percutaneous transluminal renal angiography, which can be both diagnostic as well as therapeutic. So angiography that way is very important, especially in young patients. So you can do the diagnosis as well as you can do the angiography, and you can put a stent also if it is required. So PTRA again is a very important step in management of your renal artery stenosis patients. Now this is a very small topic, but again you will be amazed by the amount of questions which they keep asking you on renal artery stenosis.